The Autism Research Institute relies on the generosity of donors like you to make this webcast possible. If you enjoy this presentation, please consider making a donation. Thank you.
Now, before we get started, I'd like to introduce our speaker. Dr. Beth Malow is Professor of Neurology and Pediatrics and Burry Chair in Cognitive Childhood Development and Director of the Vanderbilt Sleep Division and Vanderbilt Sleep Core. Dr. Malow's clinical, educational, and research programs focus on the impact of treating sleep disorders on neurological disease, with a focus on autism and related disorders of neurodevelopment. She serves as the principal investigator for Vanderbilt's Autism Speaks Autism Treatment Network site, one of 13 regional centers across North America funded to develop standards of medical care for children with autism, and she has carried out federally funded trials of melatonin and behavioral sleep education. This webinar is made possible through generous donor support, including a grant from Local 25 Boston Teamsters. If you'd like to contribute, please visit autism.com and click Donate. And now I will turn it over to Dr. Malow.
Thank you so much for the kind introduction. What we're going to do today, since people have had a lot of questions in the past when I've presented before, is I'm going to give you kind of a brief update on some areas in sleep and autism and kind of go over some basic concepts. And then I would love to open things up for a prolonged question and answer period, because I know you all have a lot of questions that we'd love to cover. And sometimes when I do an in-depth presentation, we get to the end and there's just not enough time. So we'll try something a little bit differently today, and then you can let me know how it goes. So let me go ahead and get started with the next slide. So I just wanted to mention briefly that I have received grant support from Neuron Pharmaceuticals. They make a prolonged release melatonin, and I'll mention that. And also I consult for Janssen and Vanda Pharmaceuticals, and they're working on melatonin agonists. And I'll also be discussing off-label uses of medications for pediatric sleep disorders, because there really aren't any approved medications for pediatric sleep, including autism, where we're still pretty much using medicines that have been developed for adults, unfortunately. So I wanted to start with the causes of insomnia, and these also relate. NDD means neurodevelopmental disorders, so this isn't just an autism, but I'm going to focus on autism today. And what I like to do when I talk to my colleagues or when I talk to families in clinic is I kind of focus on these three buckets, and they're overlapping buckets, but these, as you can see, these little circles kind of help me understand and explain to people that there's kind of a biological circle or bucket, there's a medical circle or bucket, and there's a behavioral circle or bucket, and they do all overlap to some extent. So just to kind of get everybody on the same page, when we say biological, we're talking about, for example, it might be genes. It might be genes that regulate our circadian rhythms or circadian clock. When are we ready to go to bed? When are we waking up? You know, how much sleep do we need? They may be neurochemical factors like melatonin processing in the brain of a child with autism. They might relate to overarousal or hyperarousal, the child who can't turn their brain off, for example, or sensory oversensitivity, where a child is more sensitive to stimuli. And I just realized I've been saying child a lot because that's the focus of what we deal with, but also certainly adults can be, adults on the spectrum can have sleep problems as well. So I'll try to, you know, if I don't address that in the presentation, I will in the Q&A. And then anxiety, BP is bipolar, OCD is obsessive compulsive disorder, ADHD is attention deficit hyperactivity disorder. These kind of overlap with psychiatric conditions, but you know, they may actually have biological or neurochemical underpinnings. And then we'll get to some of these other conditions in a moment. I just wanted to highlight something new that was published last year. Was a really nice review of clock genes, which are the genes that contribute to our circadian or biological clocks. And this was a very interesting paper. It didn't just focus on autism, it focused on bipolar disorder, schizophrenia, other mental health conditions. And they highlighted 2 studies that have basically shown that in autism, there are abnormalities in these clock genes. The first one by Nicholas et al. Found an association between 2 genes. They're called single nucleotide polymorphisms, and they were in PER1 and NPAS2. And by the way, PER1 was one of the genes that was involved in the winning of the Nobel Prize in Science last year, related to our circadian clock. So people are really paying attention to these genes and how they might impact sleep-wake patterns, again, not just in autism, but in a variety of conditions. And then Yang also did a study, and he showed that individuals with autism were more frequently having these mutations in these genes that were related to the circadian clock. And people have been thinking for a while, if you look at the top here, social timing, clock genes, and autism, and then this possible interplay of synaptic and clock genes in autism. People have been talking for a while about how these clock genes not only regulate sleep, but they regulate kind of how we converse with each other, you know, this idea of social timing. If I'm talking with you and I'm on the spectrum, I might not know to wait, you know, a long enough time to let you to respond to me, that, you know, I might jump in because I don't have that sense of social timing and the to and fro that we need for appropriate social interaction. So they're not only implicated in sleep, but just kind of in the whole way that we interact with the world around us. So I thought that was very interesting as an example of like a biological cause of insomnia in autism. And then medical causes, these are all the things like sleep apnea, seizures, GI problems, restless legs, even the medications that someone is taking for, let's say, anxiety or depression can interfere with sleep. So it's really important to think about these medical conditions and medical causes when we're dealing with autism in a child or an adult. And how do we know if somebody has sleep apnea? How do we know if they have leg movements? How do we know if they're having seizures? Well, we oftentimes need to do a sleep study, which is called polysomnography, and hook up electrodes. You know, people always laugh because I say, you're not going to sleep normally in the sleep lab. We're not really measuring your sleep. And they're like, well, it's called a sleep study. Why aren't you measuring my sleep? And we're measuring sleep, but we're not measuring normal sleep. So in other words, it's not like we're bringing somebody in the lab and saying, we're going to measure how you sleep at home. We're actually bringing someone in the lab, putting all of these wires on them. They're sleeping in an unusual place. So we're likely not going to get how they normally sleep at home. But we are going to get, are they having breathing problems? Are they having seizures? Is there something kind of going on in their sleep that's not normal? So, for example, you can see here, well, on the left, you'll see the young man, the teenager, being hooked up to all of these different wires, but he's smiling because he's got his Pokemon books, and sometimes we'll give them laptops to play with. And then lower down, you can see this very attentive sleep tech who's, again, really having great technologists who work with families, taking a family-centered approach to making sleep studies child-friendly, distracting the children, preparing them with social stories can make a big difference in terms of them tolerating a new, unfamiliar place with strange wires on them. I saw a little girl today in clinic, and I was telling her about, you're going to be a movie star, we're going to put jewelry in your hair, we're going to have something on your finger that glows, and, that made the whole experience a lot more palatable for her. And then if you look at these tracings on the right, you'll see this sharp, we call it sharp activity, it's epileptiform or sharp wave activity kind of jumping out at you in the tracing. That's evidence of seizures. And then lower down, you'll see these waves that kind of come and go, and see if I can put my cursor on it. You can see there's like the flattening of the airflow channel, and then there's a big breath with an arousal, and then it flattens again, and the oxygen level falls. We record that as well. And this is what we see in sleep apnea. So that's how we diagnose seizures and sleep apnea with the sleep study. Although if I'm really worried about insomnia, which is difficulty falling asleep or staying asleep, and I'm not as worried about sleep apnea or seizures, I'm more prone to give an actigraphy watch to a child. And this is similar to a Fitbit, except that it's research reliable, and you can the child can wear it for weeks on end, and we can get different patterns of their sleep, and they can wear this at home in their own bed, in their own room. It doesn't involve anything other than wearing a watch on their wrist. And if they have sensory sensitivities to wearing watches on the wrist, we can even, we've published on putting the watch within a tight-fitting, snug-fitting t-shirt, and we can still get the data that way in kids with sensory sensitivities. And basically, the black means they're awake. When the black dissipates, they're asleep. So you can get a nice pattern of the sleep-wake cycle throughout the night. So, for example, on this day, the child took about an hour to fall asleep. In addition to the visuals, we have quantitative data. And then this night, they took about 30 minutes to fall asleep between the time that the parent pressed the event marker and the child went to sleep. Here they fell asleep almost immediately, but they had a night waking. So you can really track this, and we like to use this Philips Respironics, but there are other devices as well that are on the market that can measure sleep-wake patterns. So then the final category is behavioral, and this is where you get into limited exercise, caffeine, screen time. Even parenting stress can affect a child's ability to go to sleep at night because the parents are stressed and sleep deprived. They're going to it's going to be harder for them to deal with meltdowns and just trying to really help the child fall asleep on their own. Sometimes parents put their kids to bed too early because they want them to get a head start on the night, but then the kids are unable to fall asleep because they're just not ready, or they have to wake up early for school, so the parents feel like they need to get them to bed earlier. So these are all things that we address in our clinics. And when we look at the treatment of insomnia, we focus a lot on these behavioral approaches because oftentimes it's not that the child isn't behaving well, but there's something going on with their sleep that's behaviorally related. There's use of caffeine or naps too late in the day, or they're just not getting enough exercise. The evening habits, making sure that they're winding down, that they're relaxing before bedtime. The sleep environment, making sure that it's comfortable and quiet, and there's sufficient light, especially if the child is anxious. And then there's a calming, soothing bedtime routine that really prepares the child for sleep. So, for example, bath time can be very soothing for a lot of kids, but for some kids it can be very stimulating, and the bath, even if they enjoy it, could rev them up. So moving the bath earlier in the evening or maybe even before dinner can be an effective strategy in those kids who are stimulated by bath. One of the simple ways that we can kind of measure sleep hygiene and figure out what tactics to take with a family to help their child sleep, we'll ask about exercise. We'll ask like these 12 questions on this family inventory of sleep habits, which we've published. Exercise, the regularity of sleep, whether they're involved in regulating, relaxing activities before bed, whether they're using caffeine, those kinds of things can be very helpful because then we can hone in and see what areas that we can focus on with the parent. We use a lot of tools such as line drawings or checklists to help promote sleep. Kids with autism just love visuals, and they also love like a structure and a routine. So kind of knowing what's next, knowing what's going to happen next can be very helpful. And even if they have limited verbal skills, we can construct a bedtime routine with photos, object schedules, cues in the environment. We can use real objects such as displayed here. And that toolkit I just showed you, along with these other ones, are available free on the internet. You can either put this long email address in, or you can just Google or use your web browser to search for Autism Speaks sleep toolkits, and they'll all pop up and you can download them for free. And I want to highlight now that we have one on melatonin, as well as these visual aids. I also wanted to highlight that since I last spoke with you, we published a paper in 2016 on adolescence, because oftentimes it's the little kids who get all the attention, but we all know the little kids are now growing up and becoming teenagers and even adults. And this is a sleep education program provided to 18 teens, ages 11 to 18 years. And basically we showed similar results to work we've done in little kids, where just a couple of sessions, this just shows screening and in the different sessions we had and follow-ups, a couple of sessions we were able to improve sleep latency from 78 minutes to 45 minutes and improve sleep efficiency, which is time in bed divided by time asleep. I'm sorry, time asleep divided by time in bed also improved, and sleepiness improved on the Epworth Sleepiness Scale, and then we had an adolescent sleep-wake scale, and a variety of measures improved, including falling asleep, maintaining sleep, and reinitiating sleep. So that was very encouraging to us. So occasionally these behavioral measures don't work and we have to turn to medications. I really advocate that we try the behavioral techniques first, because a lot of medications have side effects. And we published a practice pathway in children with insomnia and autism that really focused on, what I just went over, really make sure there's no medical condition that's affecting sleep. Use the behavioral therapies first when a family is willing and able. If the child has epilepsy or anxiety or a mood disorder, try to use a medicine that will treat that first. Use low doses to avoid excessive sedation, adverse effects. And remember, for primary insomnia, there are no FDA-approved drugs. Melatonin has been used the most, but there are lots of other things. And unfortunately, it's kind of a grab bag at this point. Kids are really on all sorts of drugs, many of which aren't necessarily effective, but these are some of the things that parents and clinicians will turn to when a child isn't sleeping. And I'm just going to highlight a few of these in the next few slides, but I just wanted to mention that even the over-the-counter drugs you have to be careful about, because like valerian root, even if it promotes sleep, interacts with benzodiazepines like Valium and Clonopin and with alcohol, which shouldn't be an issue in our kids, but other medicines that they're taking could be affected by taking valerian root. So you just want to be sure that a pediatrician is involved in if you give your child any of these over-the-counters. So I wanted to highlight there's a new form of prolonged release melatonin. We've talked about melatonin a lot in the past, and the challenge is that oftentimes you fall asleep, but it doesn't help you stay asleep because it only lasts about an hour in the system. The prolonged release lasts longer, but you have to swallow a pill because it's this coating around the pill that turns it from immediate release to prolonged release, and it lets it, be released slowly in the GI system. But there is a new tablet now that we were able to participate in a study, and it's gaining more attention throughout Europe and in this country, and hopefully they'll have approval from the Food and Drug Administration in a couple of years, and then they can have, it would be available as a prescription here. It's not available just yet. But what's nice about it is it uses like a cake sprinkle size. So it's a tiny little mini tablet that's easier to swallow, that can be mixed with applesauce, for example. And in the study that we did, we were one of the participating sites. It involved 125 children, ages 2 to 17 and a half years, and they fell asleep on average in 25 minutes, and they were asleep for longer, about 32 minutes on average. And if you look at this graph, what it's basically showing is this orange is how regular release melatonin kind of peaks and dissipates, while this extended release lasted longer. And also you didn't get the same level of high dose, so you didn't have as many side effects with it. So that's something to kind of watch for. And then I wanted to mention clonidine is interesting. A lot of people use it, but there really have only been 2 studies. One was in 17 children and one was in 6 children. So even though it was effective, we don't have a lot of data on it, and also the side effects can be very disturbing and disruptive. I mean, pallor, tachycardia, which is a fast heartbeat, hypotension, which is low blood pressure, irritability, and even increased night waking. So it could help with falling asleep, but it could interfere with staying asleep. And then I did want to mention gabapentin, because this is something that I've studied with my colleague, Dr. Robinson at Vanderbilt. Gabapentin actually doesn't work on GABA. It works on calcium channels and in the brain. And what we found is that it improves both sleep onset and sleep maintenance, insomnia. There's one, well, I wouldn't call it common side effect. I would say in about 1 out of 10 kids, there's what we call paradoxical insomnia and agitation, where they get actually more riled up from it. But that's really in just 1 out of 10 kids, and when you stop it, it goes away. So we've had a lot of success. We dose 5 milligrams per kilogram, and then we increased to 10 to 15 milligrams per kilogram over a few weeks. And we found that in this series that we reported, the majority of kids improved, even if they had tried melatonin and not responded to it in terms of sleep. And so that's kind of where I want to stop. You know, sleep problems are common. There's many causes and contributors, many of which are treatable. I didn't get into this in detail, but when kids are sleeping better, they oftentimes have better daytime functioning. They're less irritable. They do better in their therapy sessions. They do better at school. It's just like us. When we haven't slept, we feel grumpy and grouchy the next day. And the parents are also, if a parent of a child with autism is sleeping better, they're probably going to be able to advocate better for their child, whether it be in a therapy session or an IEP meeting. So we really feel like improving sleep in the kids also improves sleep in the parents, which then helps the kids. So where do we want to go with this work? And what I'll do is I'll leave this future direction slide on as we do Q&A. You know, I'd love to see large treatment studies, including randomized trials. We can include the actigraphy watch, more studies that incorporate behavioral interventions with medicines, more adolescent studies, more adult studies, you know, more studies of conditions that are similar to ASD but are different, like Rett syndrome, for example. Comparative effective studies where we can kind of look at, would melatonin plus behavioral therapy be as effective as trazodone or clonidine, for example? Really understanding the long-term efficacy. Do you need to stay on melatonin forever, for example, or could you potentially come off of it after, you know, the child has learned certain behavioral sleep techniques? Understanding the genes that contribute to sleep problems, paying attention to some of these co-occurring conditions like apnea, and putting this all together in a practice guideline. So let's say a kid with autism isn't sleeping and they come to their pediatrician. The pediatrician would be able to maybe, you know, get some saliva for genetics, or do a blood test, or just a simple history, and be able to say, you know, this is a child, all we really need to do is put a behavioral program in place with a bedtime routine, or this is someone who's going to need melatonin too, or this is somebody who's going to need a stronger drug like gabapentin. I think that would be very helpful, because the quicker that these kids are sleeping better, the easier it is on the families, and the more, you know, more progress they'll make in their therapies. So at this point, I'm going to stop and open it up to questions for the rest of the hour. Are you there, Denise?
I am here. Sorry about that.
Oh, good.
I was
No problem.
I was talking to you and I realized I was muted, so I apologize for that. Yes,
no worries.
We've had lots of questions, so I can start to read those to you. The very first one we've got is about genetics. So I know you touched a little bit on genes, and without getting too deep into a discussion, because I know that would be, we could probably talk for a couple of hours just about that.
Sure.
People have specific questions about, there's something called the MTHFR gene. There are other genes that have been pinpointed. You mentioned a couple of genes on your slide. If you want to put that slide back up, you could.
Oh, sure. Oh, that'd be great.
Yeah. Can you talk a little bit about research in that area, and if any of it is specifically guiding some of the work that you're doing using melatonin and some of these other potential treatments?
Yes. So the gene related to the methylation, I don't know specifically of any sleep work that's been done, but a lot of work is being done not just in these clock genes, but also in the way that genes metabolize drugs, because depending on your genes, you can be a fast metabolizer or a slow metabolizer of different drugs. And so, for example, even melatonin, there's evidence to show that some kids metabolize melatonin faster than others or slower than others. And you'd think that metabolizing melatonin slower would be good because there'd be more available in your system, but it's actually complicated because if you are not getting rid of your melatonin, then you tend to lose sort of the peaks and valleys that you need to have melatonin be effective as a sleep promoter, if that makes sense. We all make our own endogenous, our own melatonin in our bodies. So really paying attention to not just the genes that affect like the clock, but also metabolize these medications. Some medications, antidepressants, if you are not metabolizing them properly or fast enough, they can stick around and they could be very stimulating. So, those are the kinds of things that people are paying attention to with genes right now.
Okay, great. Next question is about, this was actually, I don't know if you know anything about this, somebody was asking about essential oils for sleep. So if there's any research about using that as a method to help people sleep.
Yeah. There are a lot of different things that people use, from essential oils to, certain sensory strategies, even mattresses or sounds. And I just wanted to talk about those in general because I really feel like you need to individualize them to the child. So if your child really enjoys a massage or the scent of an essential oil or the combination of the way the oil feels and smells, by all means, try that, because every child is different. Some will react to that. Some will react in a positive way to, let's say, music, others to certain textures. And it really is not a one-size-fits-all. Weighted blankets is another good example. So what you want to try to do is try different things and figure out what seems to calm and soothe the child. Like, I don't say to parents anymore, do you do a bedtime routine? I say, when you do the bedtime routine, is your child calm and soothed at the end of it? Because different children are going to react to different ways. And the goal is not to say everybody needs essential oils or everybody needs a certain mattress or a weighted blanket. It's more what really seems to calm my child. The only thing I would worry about is, be careful with expense. I like essential oils because they tend to not be that expensive. They're safe. But you always want to keep in mind expense and safety whenever you think about different things you can try.
Okay. So we had you talked quite a bit about melatonin, and I know that there are a variety of products on the market. So one question is sourcing. I had a question about safe sources for melatonin. Where's the best place to buy it? Does it matter? Is it fine to get at the grocery store? The other question was about dosage. So there's 1 milligram, 5 milligram, 8 milligram. There's sublingual. How do parents who are trying this over the counter make good choices about that?
Yeah, good question. So first of all, as I said earlier, let your pediatrician know that you're going to do melatonin. The only reason I would say that is melatonin, even though it's available at the, at the grocery store, still interacts with other medications. So you just want to be absolutely sure that the pediatrician is aware. If you are going to go with melatonin, I always recommend the smallest dose, 1 milligram, or even a half a milligram if you can find that. There's actually there's liquid preparations that you could give a quarter of a milligram, and I really recommend the smallest dose and then just work your way up, because if the smallest dose works, it's going to mean fewer side effects, and it's always better to use a lower dose than a higher dose. What I normally do, though, is I start with 1 milligram and then I increase by 1 milligram, let's say, every week. If they're not responding to 6 milligrams, there's probably not going to be much of a response there. And in terms of reputable brands, I did a research study with Natrol, so I recommend them. I don't have any stock in Natrol. I don't have any ongoing projects with them right now, but the Food and Drug Administration had to review their records. So it's Natrol, and they, they reviewed their records before we could do this clinical trial, and they approved using that brand. So I think it's a fairly reputable brand. You have to read the labels really carefully, because some brands will have Benadryl or something else mixed in. You'll see melatonin in combination with chocolate, which is a little bit ridiculous, because chocolate actually is a stimulant in terms of interfering with sleep. So I probably wouldn't want to give the melatonin with chocolate, or baked into brownies is another way that they give melatonin. I would stick with just the regular melatonin. And there's lots of other brands. I don't want to make it sound like you have to get that Natrol brand. I mean, there are a lot of other reputable brands on the market, but it's just that I have experience with that brand from our clinical trial.
Okay, great. So this is a question about sleep hygiene. This is a parent who it sounds like they've been battling with sleep for quite a while. So from early childhood, and now things improved. They had a routine and things had improved over time, but now we are hitting puberty and experiencing big changes. So you touched on this a little bit about the studies that you've gotten engaged with, where you're looking at adolescents. So with that puberty onset, is it fairly common to see this resume?
Yeah. So what happens in puberty, not just in kids on the spectrum, but all kids, is there's a delay in the clock, so that normally we might go to bed at 8 o'clock or 9 o'clock when we're a school-age child, let's say before puberty. And then when you go through puberty, what happens is our circadian clock gets delayed like by 2 hours on average. And some kids less and some kids more, but the kid who was able to go to bed at 8:30 or 9 is now not able to fall asleep until 11:30, like 11 or 11:30. And this isn't just in autism. This is, in typically developing kids as well. So the challenge is that if a parent puts their child to bed at 9 o'clock at night, but they're now, in puberty, and their natural bedtime is now delayed by about 2 hours, they're going to lie awake trying to fall asleep, unable to fall asleep, and they're going to start, what are they going to start doing? They're going to start doing repetitive behaviors or fidgeting or doing something that will actually interfere even more with falling asleep. It's similar to us if we have to catch a plane at 3 in the morning and we say, all right, instead of going to 10 o'clock bedtime, I'm going to go to bed at 8 o'clock, but then we're not tired at 8 because our brains are just not ready for sleep. So we start tossing and turning, and, we may not even fall asleep at all, even past 10 o'clock, because we're so worked up. So one of the things that we always recommend, particularly in teens who are going through puberty, is to try to delay bedtime if possible. That way they're ready to go to bed and they're tired. The biggest challenge we have, though, with doing that is the school start time. So if a kid is homeschooled, we can normally say go to bed 11 o'clock or midnight and you'll fall asleep quicker. You can sleep till 8 or 9. But if they have to be up at 6 a.m. to get ready for school, it can be very challenging. And, that's kind of a societal issue, this whole, like, what time should school start?
So the next question that we had, this is about dealing with behavior in adulthood.
Yeah, so I actually see kids and adults across the lifespan. I'm actually trained as an adult neurologist. I have 2 boys on the autism spectrum who are teens, so I'm very familiar with young teens and young adults. And it's just interesting to me because it's kind of coming full circle now with 50,000 individuals on the spectrum turning 18 every year. I think we're, definitely going to see more interest in adults with autism and sleep problems. So the principles are basically the same. You want your adults to have a calming, soothing bedtime routine. We'll sometimes use these medicines. The biggest differences that I've seen are while the kids oftentimes have that structure of school, the adults that I see who are having sleep problems and are on the spectrum oftentimes may not be working or aren't in school. So really trying to get them to have a regular sleep-wake cycle is harder. And what we're finding is we really need to focus on trying to work with them to find meaningful activities during the day, get them involved, if not in paid employment and volunteer work, so that they can start getting their lives back on track. Because if you're sleeping better, it can impact everything. It can impact your overall functioning. So it can impact mood. So my feeling is the first thing I would do is take a really good history, not just limited to sleep, but what's going on with the individual during the day. What kind of activities are they doing? Are they doing exercise? Are they involved in some sort of exercise program? Are they getting bright light during the day? Because all of that can be very, very, very important in terms of making sure that they get the the proper signals during the day, and make sure that they're getting as much stimulation so that they can sleep well at night. We also look out for things like sleep apnea. I brought it up in the kids, but it can be even more of an issue in the adults, particularly if they're taking medications that might result in weight gain, like some of the antipsychotic medications that are used can interfere with weight and cause weight gain. So weight gain can lead to an obstruction of the airway, a blockage of the airway, and sleep apnea, where you're not sleeping well at night and you're sleepier during the day. And then you could also wake up at night because you're trying to breathe. So we spend a lot of time looking for that. And then basically the same approach, meaningful activities during the day, some structure, regular bedtime, regular wake time, soothing, calming activities, getting off of the screens if they're gaming, making sure that they're, off of the games at least an hour before bedtime, and are doing something that doesn't involve either the stimulation or the light from the games, because the light from the games can be very stimulating and disrupt sleep. So reading a book or doing some other activity, listening to music, that will get them ready and prepared for bed.
Okay, this is a pretty specific question, so I'm going to couch it a little more generally. But we have a parent asking about sudden sleep stoppage. So this person her daughter just stopped sleeping abruptly in 2015. She wakes up at 3 a.m. every night. Sometimes she'll go back to sleep, but sometimes she doesn't. She engages in self-injury. They've done a EEG, and she's on gabapentin and risperidone. I'm probably not saying that quite correctly, but anyway, her development pediatrician is working with them on it. Have you seen the onset of sudden sleep disruption like that? And what would you be thinking in terms of maybe potential areas to probe?
Right. So let me make sure I understand. So the the child was doing okay, but recently has started waking up at like 3 in the morning,
Yep.
not being able to go back to sleep. And the bedtime is what time?
It doesn't say what time this person's
Okay.
going to bed.
Sure.
Waking up at
Sure.
3 a.m. and it came on quite
So,
suddenly. Yep.
yeah. So I would look for a medical condition first. If there's a new sudden onset where they're waking up at 3 in the morning, the two things that come to mind is something that's disrupting sleep, like I mentioned, the sleep apnea, and you might be hitting your rapid eye movement, or it's called REM sleep, around that time of the night, and that's when you might be more susceptible to breathing problems. So that's number one. The other would be something like depression, because depression, one of the key findings or symptoms is early morning waking, which could be 3 in the morning. That's why I was asking when the person goes to bed. If the person's going to bed, especially like, let's say 10 o'clock at night, 3 a.m. may be around that time that they're hitting their REM, and they're also, could have depression leading to early morning waking. So being a doctor, I always start by making sure that we don't overlook something medical. And then if there was no sleep apnea, if there was no depression, then I would be looking at things like, is there, when is the gabapentin being given? Could it be wearing off? Is there something else we might need to try? The other thing I've seen sometimes is that somebody may sleep from 8 p.m. to 3 a.m. and then they're done, or 10 p.m. to 3 a.m. and then they're done, and they've just become a short sleeper, in which case you need to say, is the amount of sleep they're getting affecting their daytime functioning, or is it more that they're just getting a short amount of sleep and they need to find other things to do that won't disrupt the family, when they are ready to get going for the day.
Okay. Yeah, the mom actually followed up and mentioned this person has an early bedtime. It looks like 7:30. So perhaps that's something that they might look at. And
so 7:30 to 3, that's actually quite a lot of sleep if you think about it. That's 8:30, 9:30, 10:30, 11:30, 12:30, 1:30, 2:30. So that's 7.5 hours of sleep. So it may be that kids need 9 to 11 hours of sleep, school-age children, and then when you get into teens, it's more like 8 to 9. What's the age of the child?
it says she's 5. She also has cerebral palsy. So.
Okay, so is she napping during the day? Do we know that?
Yeah, the parent didn't mention if she naps.
Okay, yeah. So it may be that things just need to be shifted. So a late afternoon walk, or getting exposed to a little bit of light in the late afternoon would allow the child to go to bed, let's say at 9 at night, and then if they're going to bed at 9, then they may be waking up at 5:30, which might be easier on the family. So that might be somebody where they may not need more sleep than they're getting, but if you could shift it later, it would be easier on the family.
Right. All right. The next question, this is more about melatonin. I think you mentioned they're asking about long-term use. Like you talked a little bit about using it through the lifespan. Is there any risk to long-term use? What is it? Is there a problem for teenagers? Are there any things that people should be aware of?
Right. So in terms of long-term use, as best as we know, it's fairly safe. If you look at the literature, the big area that's come up is this reproductive health, because what they've shown is that as you go through puberty, your melatonin levels drop. So like our own melatonin levels that we make in our bodies. So in other words, if you're going to give kids melatonin, the concern would be you're interfering with something that's naturally occurring where the melatonin levels drop, but you're giving them excess melatonin, and that's going to interfere with the normal development of puberty. We actually don't know if that's the case, and I think if it were the case, we would know it, because think of all the kids, not just with autism, but without autism, who get melatonin. There's a lot of kids in this country that are getting melatonin, but we really haven't heard of any concern about puberty being delayed in kids. So I tend to think it's safe, but that's the one thing you'll read about, like if you go on the internet, that they'll talk about. Other than that, I think the biggest issue is making sure that if you give melatonin, it's not interacting with other drugs that the child is taking, that what they're really getting is pure melatonin and they're not getting some other thing mixed with the melatonin. And also that the pediatrician knows about it, not just because of the drugs, but maybe like I wouldn't want to give melatonin to a kid who has sleep apnea, because what you really need to do is get that identified and treated. So other than those, like making sure the doctor knows they're using it, making sure it's a reputable brand, and they're not getting Benadryl or something else mixed in, I don't think it has any prolonged side effects. Now, with that said, I will, a lot of times parents don't want to use it forever, and I respect that. So what we might do in a child who's not falling asleep with simple behavioral techniques is add melatonin into the behavioral techniques. So like you give them melatonin 30 minutes before bedtime. They do a bedtime routine that's soothing and calming. And then the idea would be that you could take the melatonin away once you've instituted the bedtime routine, because now the child is able to do that on their own. So it doesn't have to be used forever. It could be used in a sense as a bridge while the child and the family are learning the relaxing bedtime routine.
So working on sleep hygiene and having that be the calming mechanism, but then fading it out when it's no longer necessary.
Right, because some families have a hard time doing the bedtime routine and the other aspects of sleep hygiene because their child is so sleep deprived, they're overwhelmed, that the idea of putting all these things into place is just too much. But if you can combine it with the melatonin and get the child sleeping and the family sleeping, then sometimes you can just get rid of the melatonin.
All right. I think that's most of our melatonin questions, but we do have one last one. It's actually about timing. So how long before you really want sleep onset should it be administered, or does it vary? Does it depend on the patient?
Yeah, I like to give it 30 minutes before so it gets in the system. And while you're waiting for it to go in the system, you don't want to do video games or videos. You want to do like soothing, calming activities like reading a book or listening to music or, massage, those kinds of things.
Okay, switching topics here. This is about GI health and sleep issues, so links with gastrointestinal problems and sleep. I don't know if you work on that comprehensively there in your clinic, but can you touch on any kind of research that addresses that connection?
Sure. I'm not a GI expert, but I work with GI experts, and I would say yes. GI problems, like many other medical problems, can impact on sleep, and if a child particularly has limited verbal abilities and can't express that they're constipated, or I should say an adult as well, if they can't express that they're constipated or having reflux, it can definitely impact on their sleep, because reflux can be worse at night. It's just really important, I think, in any child who's not sleeping well. I brought up sleep apnea and seizures, but there's a myriad of other medical conditions. So really trying to have those all checked out and looked at, because those can impact sleep. So the reflux could be a burning feeling or a burping feeling or a gas feeling. And again, getting that history isn't always that easy, particularly in an individual with autism who might have limited verbal skills. But there are certain, symptoms, as I said, like the bloating or whatever, that if you can either elicit them or have the GI doctor involved can be very important to identify and treat. And sometimes they'll start an anti-reflux medication or Miralax or something else for constipation in the hopes that this will, like even if you're not 100% sure this is the cause, see if that makes an impact on the sleep.
This is a question, I've gotten a couple questions actually related to both startle reflex, and you talked a little bit about restless leg, I know, and also nightmares. So what can parents do about, if their child's waking up screaming and some of these issues that are so surprising and they're alarming for the family as well?
Yeah, so screaming, you have to really figure it out. Sometimes the child is waking up scared. Sometimes they're waking up in response to reflux or something else. And then the other possibility is they're having what's called a sleep terror, which the child is actually asleep, but they wake up inconsolable, very upset. They have no recollection of the event in the morning. And those are really important to identify because those could be triggered by something like sleep apnea. They also oftentimes respond very well to small doses of benzodiazepines like Klonopin. So really understanding what it is, and sometimes we have to do sleep studies to try to figure it out. But the child is actually screaming, but they're actually asleep. So really trying to get at what is the cause, what is really going on here, because the screaming in your sleep is more of a manifestation, but it's not necessarily the cause, right? So really understanding the cause, the triggers, and that way you can start the most effective treatment.
All right. One of the tools I think you mentioned last time you did a webinar and it came up again is the FISH scale. So can you talk a little bit about that and where people might be able to get that?
Yes. So I went ahead and let me see if I can go back to my slides. The FISH scale is available for free. I probably once a month I get a request from somebody who wants to use it, and I always approve that, but I don't even need to approve it. It's published. If you go to your web browser and put Family Inventory of Sleep Habits Malow in, you'll get it. And it basically is this 12-item scale that can be very helpful in trying to understand what problems a child is having.
Okay, great.
So, we can use it. So, if I give this to a parent to fill out in clinic, and they circle that they're always having drinks and foods containing caffeine, which is question number 4, then I can really target that when I work with the family, because you can imagine it's in a clinic visit, it can be very hard. There could be a lot of different factors going on and needing to be addressed, and this is kind of a quick way to get at what might be going on with the family.
Right. And so the FISH scale, does it tackle some of those things about nutrition and some of those factors people may be challenged with? Yep.
Yeah, it doesn't really get into that as much as what are the sleep habits.
Okay.
To get into nutrition and other things, I would really say, you really want to get a good history. The pediatrician can take it, but if there's a concern about the pediatrician taking it, or the pediatrician has other things they have to contend with, I would say, a referral to a sleep specialist is another thing you can suggest to the pediatrician, or for the primary care doctor in the case of adults, a referral to a sleep specialist. You want to make sure that the sleep specialist has some expertise and interest in dealing with individuals on the autism spectrum, because sometimes they're just not equipped to do that. Right.
They want to make sure that they can untangle the different comorbidities if those exist as well. Yep. So one thing that you mentioned earlier was depression. And a parent followed up and asked, so if your child is nonverbal, is there a way to assess depression in somebody who can't speak?
Yes. That can be very, very hard. The sleep patterns can be one of the key features. whether the person appears to be, decreased facial expression, loss of interest in their usual activities, that they're used to doing during the day. So even if they can't tell you that they're depressed, those are things that, you'd want to be looking into.
Okay. A question here, they're asking about this child won't fall asleep unless mom is right next to him. So what can they do about that? So if the sleep's dependent on another person and the family can't get any peace, obviously they're shaped around that. So what could they do? What are some strategies?
Yeah, so there's a lot of different things that could be done. The co-sleeping comes up a lot because it is something oftentimes that parents don't necessarily want to co-sleep with their child, but they feel like they don't have any other options. But it really is an act of love if you can teach your child how to fall asleep on his or her own. And part of the problem, I think, is that a lot of times what we've been told you have to do to help a child fall asleep on his or her own is they have to cry it out, or you have to leave them alone and let them figure it out on their own. And that can be very hard for a parent of a child on the spectrum because they may have a lot of anxiety issues or other things going on. So we have a whole bunch of strategies. I wrote a book with a colleague of mine called Sleep Problems in Children with Autism, a guide for frazzled families. And, we really get into what are the different approaches that might work, and, how do you substitute rewards rather than punishment when a child isn't sleeping. I was in clinic this morning and I handed out 2 bedtime passes, which are little tokens where they're little, tickets where the laminated cards, and the kids can either hand them in to get into bed with mom and dad, or they can hold on to them all night long and in the morning substitute them for a reward, which could just, be a wrap presents in the dollar store. I mean, there's lots of different techniques that you can use. If a kid is co-sleeping, you could have the parent in the room with them, but they're on a separate mattress, and then you move the mattress gradually apart from the child, or they could be sitting in a chair and you could move the chair closer to the door. There's so many different strategies that focus more on, as I said, rewards and positive things. And some of those are in the book that I mentioned. And they work. They work in this group, of kids, and it really can make a big difference.